Good afternoon, everyone. Welcome to the second webinar in our Black History Month webinar series hosted by the Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sher and I'm the Associate Dean of the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing best clinical care for patients. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of Niihau, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, Iroquois, and Anishinaabe, lands that are now known as parts of Treaties 6, 7, and 8 and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, and languages and knowledge systems and cultures of all First Nations, Métis, and Inuit nations. For the housekeeping for the webinar, I'd like to highlight a few elements. So first of all, if you have any questions about technical issues or L3 programs and services, please use the chat feature at the bottom of your screen. If you have any questions for Dr. Salami, then please use the Q&A feature of the webinar. Please review any questions that have already been asked and upvote those questions you'd like to have answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be sent via email to all those that registered. Participants can claim CME credits and complete a personal development activity using the My Lifelong Learning Plan tool. And for more information, please visit this QR code. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credits. In addition, Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise. So today we're very pleased to welcome back Dr. Eniola Salami for part 2 of this series. She's going to provide an overview on sickle cell anemia, including screening, diagnosis, and counseling. Dr. Salami is an assistant professor in the Department of Family Medicine here at the University of Alberta and the inaugural Black Health Lead for the University Undergraduate Medical Program. She's a family physician working in a full-service academic clinical practice in South Edmonton. Dr. Salami has an MD from the University of Alberta and a BHSC with a concentration health and society from the University of Calgary. She's a member of several national and provincial boards and is a passionate advocate for anti-racist clinical education and Black health. So thank you so much, Eniola, for joining us, and welcome everyone to part 2 of our webinar series.
Awesome. I'm just going to share my screen. And hopefully everyone can see the screen well. So thank you so much for having me back on. I'm going to be doing a primer today on sickle cell anemia and primary care. And I just have to go to the next screen. And so conflicts of interest, I just want to display them here, but I have no financial conflicts of interest to declare. And so the objectives of this talk are to provide a brief overview of sickle cell disease, how to screen for it in primary practice, outline a simple diagnostic workup that those of us in primary care can use to help get patients diagnosed, and then also highlight some of the existing referral pathways that exist in our context to just help ease a referral and getting individuals to the specialists they need to see. And then also we're going to review some core genetic counseling principles for sickle cell disease carriers. And so I want to start off with a case study. So we have Dr. Jones running a busy clinical practice in Edmonton. His first patients are Rochelle and Michael Ford and their 8-month-old son named Ryan. And so Dr. Jones is speaking with the parents. He learns that Rochelle and Michael recently emigrated here from Liberia and have settled in Edmonton, but they're very concerned for their son who's been having spells and crying episodes over the last month. He's fussy, inconsolable, he's not walking or crawling well. They're really relieved to see Dr. Jones because it's been a while for them to get connected with primary care. In the meantime, they've been connecting with after-hours care to try and help Ryan as he goes through these episodes. On 2 occasions, they said that he had a viral infection and sent him home with symptomatic management. On his last visit, however, Rochelle was really hoping to get blood testing done because she knew that she was a sickle cell carrier. Her husband doesn't have blood screening done yet, and so his status is unknown. And she was concerned that this may represent a pain crisis. The doctor was not as convinced, and advised Tylenol for pain control, but the parents were quite worried and have been having to take some time off in order to try and manage things with their child. And so we're going to take a pause from the case, just as that's percolating, to talk a little bit about sickle cell disease in Alberta. And so it's important to note that sickle cell disease and sickle cell trait is more prevalent in our population than people often realize. So 1 in 128 infants in Alberta will be born with sickle cell trait. And then the prevalence in some communities can be as high as 1 in 400. And there are 6,500 people documented thus far that we have data on who have sickle cell disease in our nation. This disease and this condition and the trait tends to predominate in African, Mediterranean, Middle Eastern, and Asian communities. And it's just important to kind of note that because Alberta is a global province with so many people coming from so many different places, there's more of this in the community than people initially anticipate. There's a lot of different variants of sickle cell disease that we can see. And so, as we know, it is a mutation in the beta globin gene that results in hemoglobin S formation. And that hemoglobin S formation changes the shape of the red blood cell. So it goes from being a biconcave disc to being a sickled shape. And those sickled red blood cells tend to move not as effectively through your vessels. And that has widespread effects throughout the body and affects multiple body systems, including the eyes, the cerebrovascular circulation in the brain, the heart, the kidneys. It can affect the bones and the joints and create a whole host of symptomatology that we see in the condition. Another thing that's important for individuals to know is that there's various genotypes of sickle cell disease. And so individuals can manifest sickle cell disease by having 2 copies of HBS, which is commonly what people think about. However, you can also be heterozygous for 2 different mutations of the beta globin gene and still manifest as someone who has sickle cell disease. And so you have AS and SS, which is the typical alleles that we look at, but you can also have hemoglobin C disease, HBSC. You can have sickle cell beta plus thalassemia, which is HBS beta positive, and sickle beta 0 thalassemia. So the 2 asterisks indicate the genotypes that are more associated with more significant disease burden. So individuals with HBSS genotypes, as well as individuals with sickle beta 0 thalassemia, tend to have more severe presentations. Sickle cell trait refers to individuals who have 1 affected beta globin gene mutation. These individuals are often asymptomatic. However, it's not necessarily that they won't have any symptoms at all, but they certainly don't meet the threshold for sickle cell disease. One thing that's important to note for sickle cell disease, and part of the reason why I chose to speak about it in our Black History Month series, is that it's often been associated with Black health, right? So sickle cell disease and the relationship between sickle cell anemia and Black race is complex and long-standing. And for a long time in the medical establishment, there was this understanding that Blackness is a biological reality rather than a social construct. And people thought about specific Black diseases and Black traits. And sickle cell anemia was part of that schema. It was part of that way that people contextualized Black concerns in the medical sphere. And so in that way, sickle cell disease quickly became a Black disease, particularly in the context of North America, where there was a great deal of anti-Black racism in medical treatment and quite a bit of segregationist medical care. And so in that regard, you tend to have quite a bit of sort of understandings of sickle cell anemia as primarily being a Black disease in and of itself, when, as we saw at the top of the presentation, it can affect quite a few different ethnicities and racial groups. What is also concerning is that a lot of Black sickle cell disease patients often experience delayed symptom management, discriminatory medical care, and poor outcomes, which we'll speak about as we go through our case and go through the presentation. But it's generally something that people will talk about in terms of the stigma of living with this condition. And so with that context in mind, let's return to the case. And we can see here that basically the starting point is a really strong HPI and a really detailed physical examination, which is what we would do for any well child care in primary care. We can see here that Ryan was born at 40 weeks gestation via C-section in Monrovia, which is the capital of Liberia. The prenatal care was complete and uneventful, and there was no complications at the time. We see that Ryan eats a varied diet. He's recently started solids. His immunizations are up to date, and he's been using Advil for pain management with his ongoing concerns. He has a slight delay in speech, but has been catching up and otherwise has had normal development. His mom has sickle cell trait, and his father has no hemoglobin screen on record. And as we can see on the physical exam, the real pertinent positives there are that we have some slightly yellowed conjunctiva, an abdomen that is soft and non-tender. However, the spleen is partially palpable. He has some swollen fingers and a swollen ankle, but he's bright and reactive. But you notice that he's not really moving around. He's not really crawling, right? And so this takes us to the idea of clinical pearl number 1, which is that infants with sickle cell disease may appear more normal at birth and may have normal growth parameters early in life. Screening early and is essential for detection. And so this brings us to the idea of when do you test and how are things tested for in Alberta, aside from what you look for in your clinical examination. Alberta is one of the provinces that does have a newborn screening program for sickle cell disease. However, not all infants with sickle cell disease will be detected through the screening program. This is because as individual infants age, their hemoglobin shifts from hemoglobin F or fetal hemoglobin to their more mature hemoglobin. And it takes that transition to actually start to see the manifestations of disease. And so some infants don't manifest symptoms until 6 months of age. And so as such, symptomatic screening is essential for infants and target populations. So for an individual like Ryan, where you're starting to see the manifestation of certain conditions, and you have an individual coming from a higher target population, actually going forward and doing a hemoglobinopathy assessment would be essential to get an early and a prudent diagnosis. Currently, in terms of how things work at Alberta Precision Labs for us in this context, all positive screens on the newborn screening program are referred to the on-call pediatric hematologist, who then contacts the primary care provider to let them know about the positive screen and the suggested test that will come after. And so that is actually quite robust when you look across the country. And it was only in recent years that individuals have been adding sickle cell disease to newborn heel pokes. In Alberta, it started in approximately 2018 is when they were first able to do these things. And there has been lots of studies that have been showing the improvement in recognition and diagnosis here in our context. It's also important for us to think about how do these things show up in these infants who start to have the manifestation of the condition. These are 5 of the most common, but by no means is this an exhaustive list of how it manifests. Anemia is a big one. So having chronic anemia, signs of hemolysis, reticulocytosis, so the development of those blood cells being pushed out of the bone marrow. Individuals can present in a aplastic crisis with sickle cell anemia, which is a very severe presentation that often necessitates emergency care. Acute chest syndrome is also a very common presentation that individuals can see. People can have pneumonia-like illnesses, fever, chest pain, cough, they may be hypoxic. But the important thing to think about for the acute chest syndrome is that it can look like a respiratory illness. So as you can imagine, when you're in primary care and you're seeing a bunch of children who have respiratory illnesses, if you don't have an attunement to the potential of this disease manifesting in that patient, it could be very easy to see this as an ongoing repeated respiratory illnesses, which we often see in kids who attend daycare and aggregate care. Jaundice is another thing that we can see manifest in these patients, particularly if they have hemolytic symptoms, so yellowed conjunctiva and yellowed skin. For individuals who are heavily melanated, yellowing of the skin may look different, so it is helpful to see different skin manifestations of jaundice, particularly for anyone who's joining us who's in training. It is helpful to look at resources like Mind the Gap, where you can actually see different skin presentations on different levels of melanation. Splenic pooling is also another presentation we can see. So people can have an enlarged spleen with all of those sickled cells collecting in there and causing sequestration. So this can cause left-sided abdominal pain, a palpable spleen on exam. Hemodynamic compromise and hypotension is a really, really severe consequence of this particular presentation and is an emergency. So if there is a concern for an individual who has a palpable spleen with hypotension, you would, of course, refer that child to the stollery for urgent management. And a big one that we can see is pain crises. So sickle cell anemia causes a significant amount of chronic pain. Individuals can have pain and swelling to the limbs. They can have dactylitis. They can also have vascular compromise and vascular pain and vascular manifestations. So ischemic changes to the skin, ischemic changes to areas of the body. And it really, really can be very, very limiting for a lot of children and adults. And it's often a presentation that ends up in emerge. Individuals often will present to emerge with pain crises because they often need intravenous pain management in order to deal with the severity of the pain crisis itself. So when it comes to testing, when an individual gets a positive newborn screen, these are the tests that you would do after the fact to confirm your diagnosis. So having a complete blood count with differential would be essential to see for anemia. The hemoglobinopathy investigation panel here in the Alberta context includes HbA, HbA2, HbF, HbS, and the HbC percentages, and is interpreted for us and helps us know if an individual has the condition or not. Getting a lactate haptoglobin and a peripheral blood smear is also important to see if there is hemolysis and to actually see the actual morphology of the red cells themselves. A reticulocyte count is also important to see the function of the bone marrow and to see the progression from the reticulocyte to the sickled cell. Bilirubin is also important. As you saw in the prior slides on the common presentations, individuals can manifest jaundice when they have this condition, so having conjugated and unconjugated bilirubin is helpful. If an individual is febrile at presentation, it is important for you to do a blood culture or a urine culture, and also to get a sense of the chest x-ray is another thing you could think about in terms of a septic workout. Sepsis is the most serious complication infection-wise for individuals with sickle cell disease in the pediatric populations. It has the highest rates of mortality. So if an individual actually has a febrile illness or has an infection at the time of diagnosis, it's important for us to treat it promptly. Getting liver enzymes is also incredibly important, as well as getting a serum creatinine, sodium, and potassium. Imaging, as I said, if you have a suspicion for a chest crisis as well as for infectious disease concerns, a chest x-ray is really helpful. Transcranial Doppler is something that often will start at 2 years of age for patients with sickle cell anemia, and it's meant to test to see for their cerebrovascular circulation. And so you'll often see in patients with sickle cell anemia who are in pediatric populations that they have this done at a fairly regular interval to ensure that their cerebrovascular circulation is good. So we go back to the case. So Dr. Jones orders a battery of tests for Ryan on an urgent basis. Several days later, it is confirmed that Ryan has sickle cell disease. And so the clinical pearl 2 that I want to bring to the attention of the group is that Alberta has established sickle cell care programming. Early referral is critical, but we are blessed to actually have a program that individuals can go to. And so the one that I want to draw attention to is the pediatric hematology clinic at the Stollery Children's. And so they have the pediatric comprehensive sickle cell program of Northern Alberta, which is an excellent program. They offered wraparound services for the patient, clear protocols for ER presentations, nurse practitioner support, parental support. And so they're a really excellent resource for patients who have these conditions. Personally, as a practitioner and a practitioner who sees patients with sickle cell disease, they've been an excellent resource also in terms of asking questions. So I can call them, I can ask questions about screening, infection prevention, what my role is as a primary care provider, and they're incredibly conciliatory and helpful. So I really encourage individuals to actually reach out and call and ask questions if they have them, because they've been very helpful to me in that regard as well. And as you can see, there's other individuals who are, other individual programs that are under the pediatric hematology umbrella there, in particular the Akabudu Comprehensive Center for Bleeding Disorders, as well as the Comprehensive Chelation Clinic. And access to this, you can find out how to access it through the referral directory. I use this program pre-Connect Care, and so I did actually fax in, but there is a Connect Care referral pathway that you can use to refer patients to this program. I also often find that individuals who have this condition will often have a pediatrician as well in tandem. So I tend to operate in a team, but this is something that you can refer to as a primary care practitioner on your own. And so clinical pearl 3, which is what we'll get into next, is what the primary care management of sickle cell disease centers on. And it's three main focuses. The first is infection prevention, the second is pain management, and the third is the maintenance of disease-modifying therapies. And so when we think about the therapeutic treatment of sickle cell disease, often as an individual in family medicine, I'm not the one who is necessarily initiating the therapies, but I am the one who is monitoring and helping the pediatric hematologist in terms of seeing how the patient is when they're in between appointments. And so when I think about the therapeutic monitoring that's necessary, I like to separate it into two pieces, really. One is around what is disease modifying, and then one is around what is complication prevention. So in terms of disease modification, one of the mainstays of therapy is hydroxyurea. So it's often combined with erythropoietin, and it functions to increase HbF. The important thing for us to think about as primary care providers is what are the complications that we should be watching out for so that we can actually connect with hematology in a timely fashion. Some of the things that we can think about for these patients who are on hydroxyurea is chronic leg ulcers, headaches, changes to the integument, so individuals can have changes to their skin complexion, and it also can cause GI distress. And so it's helpful to actually ask about this with our patients to see whether or not they're having these conditions and how significant it is. Another therapy that you may see is L-glutamine. So this is for individuals who are greater than 5 years of age. They find that it reduces morbidity and hospitalization. However, especially in patients who are pediatric, you can have nausea, joint pain, and fatigue, which, as you can imagine, can cause some complications for children who are going to daycare or who are school-aged. And so it's something to think about and to ask about. Another therapy that you may see is crizanlizumab, which I always struggle to say. This is usually what you'll see in your adolescents, so patients over 16 years of age. It's a monthly infusion, and it helps to prevent cell adhesion. So as I said earlier at the top of the presentation, a lot of the manifestations of sickle cell disease have to do with the altered morphology of the cell and how it actually manifests in a lot of complications. So it can cause infarcts, it can cause clots, it can cause damage to the vessels and damage to the end organs. And so preventing cell adhesion can actually help improve the laminar flow of the blood and reduce the complications. Individuals with sickle cell disease will often have blood transfusions as well. So you will see your patients going in and out of having transfusions at various points in their course. And then individuals can also have bone marrow transplants as a disease-modifying therapy. This can be potentially curative for folks. However, not every individual is a candidate for bone marrow transplant, and access to bone marrow transplant is a complex process. So individuals can be on those medical therapies for quite some time before they even consider bone marrow transplant, if it's even considered at all. When we look at complication prevention, which is where a big part of our job as primary care providers can be, the biggest thing is remembering the immunizations. So having immunizations up to date are critical for all patients, but in particular for people with sickle cell disease, it's really important. They have decreased splenic function, and for those who have had a splenic infarct or a splenic crisis where their spleen has been removed, they're asplenic. And so the things that we're really conscious about is H-flu, meningococcal diseases, pneumococcal diseases, as well as Hep B and tetanus. And so it's really important to make sure that individuals are up to date for their immunizations and that infection prevention is top of mind. I also find that it's really helpful to have a bit of a protocol of what to do for sick days. So having an understanding of how your patient can access the clinic quickly, can be seen quickly, can have assessment quickly for any sort of infectious management is really helpful in terms of knowing how you can catch things early and refer them early. And I found that in my practice, that's been really helpful of the patients in my panel who have this condition, how they can actually quickly get from phone call to MD and actually have a management plan has been really helpful in terms of getting on top of infectious concerns quickly. Antibiotic prophylaxis is also a mainstay in terms of complication prevention. And so individuals will be on a daily prophylactic Pen-VK or amoxicillin from the ages of 2 months to 5 years of age, and it will be lifelong if their spleen is removed. And again, this is related to the data showing that sepsis and infection is the complication that causes the highest mortality for pediatric patients especially. Chronic pain is a big part of sickle cell anemia, as I said before. And so management of pain crises is also another big part of what we will see in primary care, especially if we have a good relationship with our patient and they know that they can speak to us in terms of systems navigation and support. But it's important for us to understand that individuals will frequently need to seek emergency care for pain crises. Unfortunately, patients with sickle cell disease face significant stigma when seeking pain relief during crises, and they're often mislabeled as drug seeking, and this can lead to delays in proper care. Opioid analgesia is the first-line therapy for sickle cell-related pain. And so when an individual is having repeated crises and is repeatedly showing up to emerge, this can be a difficult thing. And so oftentimes individuals will have various interventions that can help them, whether it's having a kid clock card if they're an individual who's pediatric, having a medical alert bracelet, having a protocol set up with their hematologist. There's so many different ways that individuals can manage this so that they can have analgesia promptly. But it is important for us to understand as primary care providers that our patients with sickle cell disease often face a lot of resistance or stigma, both external and internalized, when it comes to seeking pain management. So in addition to having episodic or chronic opioid pain management, there has been some limited evidence for the use of TCAs, gabapentin, and SNRIs for the pain. However, it is not the mainstay and is not the first-line therapy, but those are some of the things that you may see as part of your patient's regimen if you are treating an individual with sickle cell disease. Another thing that's really important for us in primary care when it comes to the management of sickle cell disease is monitoring. So in addition to doing management around monitoring their disease-modifying therapies as well as infection prevention, we're also going to be looking for end organ complications. Because we will often see these patients more often, we have an opportunity to actually do a symptomatic screen, often as part of our comprehensive physicals or periodic health exams. And so having a systematic approach is really helpful so that we don't miss assessments. So creating EMR templates and reminders is really helpful for this. And so as you see here from this screening page from Omino and Rotz, there's a way that we can sort of chunk out what the important and necessary end organ batteries that we should look at are. So looking at nephropathy, so screening annually for albuminuria is really important. Looking for protein excretion is really important as well. For the pulmonary side, testing for respiratory problems, having regular pulmonary testing, and monitoring for acute chest crises. Making sure that hypertension is treated and the blood pressure is under control is really important. And it is important for individuals to have regular retinal exams with an ophthalmologist, particularly because the sickled cells can cause a lot of damage in the delicate vasculature of the eye. Screening for stroke is often limited to children, and it is often done by that Doppler that I mentioned in the previous slide when we were in the earlier part of the case. Leg ulcers is a big thing, so making sure you do a regular leg examination for these patients is really important, and particularly because these ulcers can become infected, it's important to make sure that they are clean and dry and well attended to from a wound care perspective. And reproductive counseling we will come to in coming slides. So aside from monitoring and the medical therapy, what else can we offer patients? As I have alluded to throughout this presentation thus far, sickle cell disease is an all-encompassing condition that has a lot of effects for an individual. It can cause a lot of limitation in their ability to go to school, their ability to work, especially if they're having a lot of crises. It may require accommodations, right? Individuals can have limitation in their activities. And so it's really helpful for individuals to have, aside from their medical management, supports in place. And this is just a small smattering of ones that you can use, but they're ones that I think are really useful that I want to bring your attention to. So the first is the SKIP action plan. So this is an excellent resource put together by the Sickle Cell Awareness Group of Ontario in conjunction with the Sickle Cell Anemia Association of Quebec. And it is a pain relief plan that patients and parents can use to document how they can manage pain crises, what to do when they get to the emerge triage, and what kind of therapies are effective. Another great resource for folks is the Health Quality Ontario has a patient guide that offers an advocacy framework for sickle cell patients and their families. It talks about what they should expect in terms of diagnosis, pain crises management, monitoring, as well as infection prevention, and essentially makes the clinical guideline translatable for patients in easy to understand language. And that can really help people navigate some of the many appointments that they will have as they interact with the medical system. Another really cool resource is I Can Cope. So I Can Cope is an app that was made in Canada to help individuals deal with pain crises. And so it's helpful for adolescents. It was originally developed for adolescents, but it's also useful for your adult patients as well. And so this is something that you can make available for your patients that they can use. And they're resources that we can also use in conjunction with our overall medical management plan. So let's go back to the case. So it's a year later. Dr. Jones has a follow-up with the family. Ryan was promptly referred to pediatric hematology after his initial testing, and the therapies were quickly initiated. He's been doing well on his treatment and he's thriving. Rochelle and Michael have settled into their new community and are looking to expand their family. Michael is keen to have his hemoglobinopathy screen completed, and the family would like to access preconception planning. So another thing that's important for us in primary care is the idea of genetic counseling around sickle cell disease. So sickle cell disease is an autosomal recessive condition. So carrier-carrier couples have a 1 in 4 risk of having a child with sickle cell disease. So when we look at the SOGC guidelines for genetic counseling around this condition, we really encourage patients from endemic regions or ethnic groups to be screened pre-conception with a hemoglobinopathy screen and a complete blood count, just so individuals know what their status is as they're preparing to expand their family. If both partners screen positive for sickle cell trait, they should be referred to genetic counseling. So for us, it would be a Connect Care referral to medical genetics for them to have preconception counseling. And then prenatal diagnostic testing should be offered if a patient presents pregnant prior to screening. There are also certain ultrasound conditions that you'll see prenatally that will necessitate both an MFM consult as well as medical genetics, one of which is hydrops fetalis. So if that's seen, prompt MFM, maternal fetal medicine consultation, as well as genetic counseling would be recommended for that patient as well. So in conclusion, sickle cell disease is more common in Alberta than people think. So because we are a global province with a lot of people from all around the world, it's important for us to think about it in our differentials and consider it for patients. Early assessment and detection is essential for reduction of morbidity and mortality, and the common presentation can help guide clinical assessment. As you can see, most of our clinical assessment will mirror the well child care that we know well. However, we do have to have an increased index of suspicion for some of these more acute presentations. Continued monitoring for end organ complications and support for chronic pain management are critical in our role as the primary care physician. And persons who can become pregnant and their partners need prompt and effective screening so that they can plan preconception. I wanted to show folks some of the resources that are available for sickle cell patients and also for ourselves as practitioners to learn more. The Sickle Cell Foundation of Alberta has excellent resources for patients and providers about how to support and best treat patients with sickle cell disease. They also have a great resource page themselves, so I would really encourage you to go there and look at it. The NIH has an evidence-based guide for sickle cell disease management. With current NIH setup, you want to use it in conjunction with other forms of sickle cell management just because it's not being updated as quickly given certain changes in their funding and how they're being managed. But in the interim, it does have a lot of good information. Pain management guideline for sickle cell disease from My Health Alberta is also an excellent resource that you can provide to patients. The Sickle Cell Disease Association of Canada, also an excellent place for physician resources as well as patient-facing resources. And the CanHEM consensus statement is really a very comprehensive management guideline. It covers everything from infection prevention, pediatric to adult transition, how to manage crises, vascular complications. It's an excellent resource for everything you need to know for management and to help patients navigate and for you to understand what's happening from the hematology side as well as from our side and what we're responsible for. I also wanted to offer some readings that are really interesting for people who want to know more about sickle cell disease, not just from a medical management standpoint, but also from a sociological standpoint. So these are some books that are really quite helpful. So In the Blood, Sickle Cell Anemia and the Politics of Race is a very interesting read from Melbourne Tapper, talking about some of those concepts that I introduced in this talk around the connection between Black identity and sickle cell disease and how that's manifested medical racism, particularly in the United States. Dr. Keith Wei-Liu's book, Dying in the City of Blues, Sickle Cell Anemia and the Politics of Race and Health, is another excellent book on this as well. And then Dr. Simon Dyson's book, Sickle Cell and the Social Sciences, Health, Racism, and Disablement, is a really excellent take on the ableism concerns that are related to sickle cell disease in terms of how it manifests in disability rights and disability advocacy. And so those are my references. Thank you folks so much for your attention, and then I'll turn it over for questions. And so I'm going into the Q&A here. And so the first question I have here is, how come the Alberta screen for 12 newborn conditions, but sickle cell disease is not one of them? So sickle cell disease is actually screened for in the newborn screening. So it is one of the diseases. It's been screened for since 2018. So there is an existing program. So we have a program, Ontario has a program, Quebec has a program. So individuals will actually be able to be referred to a pediatric hematologist if they screen positive. And then I have, I'll let Denise go here.
Slow down, slow down. We got time. We got time. Just a follow on for that, because you were sharing about that shift in the hemoglobin more at 6 months. So is there any notion or protocol about perhaps a follow-up screen in kiddies where they might be of higher risk, perhaps if we know about the parent status and things? Like, would you recommend doing another screen at 6 months, or?
I would personally think that that's a prudent thing to do. There is no existing guideline on that I was able to find. However, I do think it would be prudent in individuals who have high risk parentage to do a repeat screen, considering that it may not manifest until later. And so when you look at the AHS guideline, it does really emphasize symptomatic screening. So I think it would be prudent to do a repeat testing at 6 months, especially if you have a patient where you know that both parents are carriers. It would be prudent to do.
Okay, and then our colleague Michael is asking, in the event that there's no primary care provider, would a positive screen result be made known via public health or direct disclosure to the family, or does the PED team take it on directly, or how is that being handled?
So when I looked at the APL guideline as well as the AHS guideline, it wasn't exactly clear what would happen in the event that a patient didn't have a primary care provider. But I would anticipate that pediatric hematology would be the first point of call. However, there's no specific algorithm that shows that they would be accepted immediately. So I would have to actually look further into that to see. But currently the guideline doesn't specify anybody other than the primary care provider.
Okay, cool. And then Catherine's asking, is the concept of a stable state PCV still a thing in the management of sickle cell, especially with regards to indications for blood transfusion?
I didn't actually see that come up when I was looking at the CanHeme guidelines, so I'd actually have to look and compare to see. But that wasn't something that I saw consistently when I was doing my research for this presentation.
Okay, awesome. Okay, folks, feel free to chime in with more questions. But in the meantime, Eniola, could you talk a little bit about prognosis? So it sounds like from what you were sharing that if the screening happens early and treatment starts right away, that's beneficial. But what is the prognosis like for these kiddos over time? You mentioned a couple of the HBSS and the HBS B0 were perhaps more problematic phenotypes, but can you give us a sense of the different prognosis and what's modifiable with these disease modifying therapies? Like, what could families, sort of have as an set of expectations?
For sure. So with regards to the prognosis, generally speaking, individuals with HBSS and individuals with sickle cell beta 0 thalassemia have a lesser life expectancy and a worse prognosis, simply because the sickling of the cells is more severe and they tend to have more complications. Individuals with the other serotypes actually perform far better in terms of management. With regards to the things that are most life limiting with sickle cell disease, the first, of course, is sepsis, so infection, and the second is cerebrovascular incidents as well as clotting events. And so, in terms of what is modifiable for patients, the most important thing is the prevention of cerebrovascular complications, the prevention of infection complications, as well as the prevention of clots, right? And so, the things that are really helpful are those treatments that help to manage those severe complications that are most life limiting. And so when we look at the data, hydroxyurea as well as crizanlizumab have been really helpful in terms of reducing morbidity and mortality by improving the laminar flow of the blood and reducing those acute incidents that can lead to lethal complications, as well as most of the data has really showed that the reduction of infection, particularly as it pertains to acute chest crises, as well as to sepsis, are really disease modifying. I find that when you have the conversation with patients, particularly pediatric patients, it's helpful to talk about how the disease modifying medications can actually reduce the amount of morbidity and mortality over the lifespan, and really emphasizing how the reduction in acute crises and acute infections and acute events is most important. Generally speaking, when I look at the conversation between patients and hematologists and ourselves, they don't give a specific prognosis in terms of this is how many years you can expect, or this is your average life expectancy, but they tend to focus more on how do we do what is disease modifying for the patient. And particularly now with the advent of transplantation, there are individuals with sickle cell disease who have a transplant, a bone marrow transplant, and live lives without any manifestations of the condition, and have a very good life expectancy. And so as the therapies have been evolving, the morbidity and mortality prognosis has been improving steadily. And so another thing that is important to talk about that is that individuals may come to you to talk about the transplantation as an option, even if their child is very young. And so in those instances, I often have them speak with their hematologist in terms of whether or not it's suitable for them. I've encountered where a lot of individuals have thought about that in terms of something that can improve their prognosis as a singular therapy. And so working with the team to ensure that you have a really good conversation around that is really helpful.
Okay. Thanks, Eniola. Kenneth has a question regarding with lifelong antibiotics, how common is antibiotic resistance?
For the purposes of this presentation, I didn't actually look at the specific rates of antibiotic resistance. Generally speaking, the only individuals who are on antibiotics lifelong are individuals who no longer have a spleen. The vast majority of individuals who are on prophylactic antibiotics tend to stop it at the age of 5. And so I would have to do a little bit more research to see how that actually functions in individuals with sickle cell disease and asplenia, who would be the individuals who would be on amoxicillin or pen-VK very long term. But generally speaking, the timing for individuals being on it is really coinciding with that sepsis hotspot between 2 months and 5 years. But it would be something that would be helpful to look at, particularly from our infectious diseases colleagues, to see what the antimicrobial stewardship would be there.
Okay. Okay, folks, you can feel free to chime in. Eniola, you speak very quickly, but very comprehensively. I did want to go back because I was a little bit, you had shared a little bit about the medications and some of the side effects. And I was just wondering, to what extent are those side effects sort of limiting for the kiddies in terms of being able to tolerate the medicines? Are there things that can be done to try to make the side effects less severe? Because obviously it sounds like these meds are really, really helpful and important. So how do you practically kind of navigate, a little one who might be really reluctant to take the medication because of the side effects? And yeah, is there things that you do in your practice?
Yeah, for sure. So the first thing that I always like to do is I like to do a 3 monthly checkup with all the kiddos who have sickle cell disease in my practice for what I call kind of my side effect checkup, where I go through the main things and keep a bit of a battery of what has been the most limiting. For every patient, it's different. For some people, it's the nausea. For some people, it's the joint pain. For some people, it's the fatigue. For some individuals, they really struggle with ulcers, right? And so having that battery every 3 months helps me know what is the top of the list. With regards to nausea, I tend to use over-the-counter nausea medication, so a Gravol, whether it's the diphenhydramine or it's using a ginger formulation. I also have recommendations in terms of taking small meals 5 times a day, so avoiding having a big meal. Thinking about what are dietary triggers that make the nausea worse, so I try and troubleshoot that with patients around the nausea management. With regards to the leg ulcers, I always do a leg check. So I like to look at the periphery. So hands, arms, legs, take a look at the skin, make sure that it's looking healthy. Where we work, we have the benefit of having wound care supplies and also having wound care access. So if I see a wound that's chronic, I do definitely get wound care more promptly, particularly for kiddos who are out and playing and can get their wounds not so clean. It's helpful to have a bit of a management plan. So I often do this in conjunction with parents around how do I keep this clean? What are the signs that it's getting infected? What are the signs that this wound is getting deeper? When should you come and see me? What kind of material should you do? I often will do the dressing in the presence of the parent or the caregiver so they can see how I do it, or I get help from the RN around that. With regards to the fatigue, I find that that's the most challenging. Generally speaking, folks, when they're taking these medications will feel better, but some individuals, especially when they're starting the medication, can have quite a bit of fatigue. For there, I spend a lot of time really working on the accommodations, particularly for school-aged patients, which is something that I didn't quite touch on in the presentation, but is important to talk about, is that individuals with sickle cell disease have a chronic disease that may manifest in their school and working life. And so being really proactive around getting accommodations for students is really helpful. You know, can you sit out from gym when you're having a crisis or a flare of your condition? Can you get extensions on assignments? Can you get added help, like getting a note taker or being able to get added help on assignments? These things can be really helpful for that energy management, which is what I find has been most effective for my patients, particularly from like 12 to 18 and into university is where you tend to see things really increase. And so it can't be lost that accommodations are a big thing for this patient population. And so I ask about it early. So for instance, for school-aged children, as part of their comprehensive, I often ask their caregiver or their guardian or themselves, hey, do you have an individualized program plan with your school? Do you have accommodations at your school? If so, who manages those? If you have a crisis at school, what is your nursing support on site, or how does that work? You know, making sure those medical letters are put together. I find that that's really helpful because inevitably individuals will have periods where they're more fatigued and less fatigued. But if there's actual supports in place, it's really helpful for the patient in terms of having less pressure on and having more accommodations for being able to rest and take their time. So that's something that I think is really important. And as they get into the working and employment world, it can become even more challenging in terms of advocating for your patients of what they need in terms of gradual work or having to take breaks or needing time off for medical appointments and the like.
Wow. Okay, that's so much. That's really comprehensive. So for the little Ryan in this case, with the not wanting to crawl and with the really swollen feet and limbs and stuff. So if he gets started right away on that hydroxyurea, do you typically see a real improvement right away in those symptoms, or are there other things that you do to try to help with those symptoms as well in that age group?
Yeah, I tend to couple their disease modifying therapies with also pain management therapies. So for individuals such as himself, you'd also couple that with some anti-inflammatory medication as well. I tend to see individuals fairly rapidly once they've started on the medication. So I'll see them within a month, and then I see them once a month for 3 months, and then stretch that longer and longer as I see symptom resolution. What I will say is that the hematology program is incredibly responsive, so they tend to give you information as well at the meantime. So I tend to get updates on how is the therapy changing, what are the things that they want me to look for, how I'm supposed to manage it. So I've been really lucky in that who I've worked with has been very explicit of Dr. Salami, I want you to look at this, this, and this. And so for each individual patient, they'll actually tell you what should you expect. How fast should you see symptom resolution? In my experience, for individuals who have dactylitis or joint manifestations, I usually see an improvement within the first 1 to 3 months. If it extends anything beyond that, I'm usually getting involved with hematology to say, hey, I'm not seeing the progression that you expect. What's my next steps? Or, hey, you need to see somebody quite quickly. Um,
I think there's a hand up, Eniola. I think Natasha is going
Yeah,
to.
I'm just gonna let Ashley ask her question here.
Yeah, awesome.
All right. Hi,
Uh,
Ashley.
I think Ashley, you're still on mute. Can we hear you? I don't hear her. Do you guys hear her? Do you want to
No.
type? Do you want to type it in the Q&A, Ashley? If you or it'd be it's try to come off mute if you want to ask your question, or just type it and we'll look. Um, so and Anila, just while we're waiting for Ashley to type her question in, you mentioned opioids as being the mainstay, but how old are kids when you would start opioids for this? Would they be bigger, presumably, or?
Not necessarily. So even when I looked at the CAN-HEAM guidelines as well as in the CPS guidelines, individuals are started on opioids fairly early, even as early as like preschool age and into school age. But generally speaking, it's under the supervision of either Peds Emerge or hematology for those sorts of implementations. And the reason being is that all the other modalities have such limited evidence for actually reducing pain. So there was some studies that looked at the use of anti-inflammatories but found that it wasn't particularly effective. And so when you look at the guidelines, opioids are considered first line across the board. However, how it's administered and under what level of supervision is different depending on the individual and the age of the patient. But yeah, it's something that you look at and you're kind of like, how would I manage that in the community? And generally speaking, when you look at the body of evidence, the idea is that you would get in touch with a specialist to help you manage it at the same time. And a lot of the crisis management is really focused on in emergent care management in terms of like door to analgesia time, essentially.
Right, right. I see what you mean. Yeah. Actually, it looks like we got the question into the chat. Andrew is asking, I was wondering at what stage of the disease or age patients are typically considered eligible for bone marrow transplant here in Alberta. And then a little more detail around what role family physicians play before and after transplant, particularly around identifying candidates early, supporting families through decision making, providing long-term follow-up. Yeah, so thanks, Andrea.
Yeah. So generally speaking, in my experience with the comprehensive sickle cell program, is that a lot of that consideration, a lot of that discussion actually happens with them. And so I'm more so on the monitoring side as well as the diagnostic side. And I have been invited into conversations, but that conversation is generally led by hematology. Each individual patient is different. And so I haven't seen a consistent eligibility cutoff. Individuals are actually individually assessed to see who would benefit the most. In terms of what we are able to do as primary care providers, identifying individuals having the condition early is the biggest contribution we can have. Is identifying them, getting them connected to comprehensive care, and getting them connected to a pediatric hematologist. Beyond that, a lot of those considerations are actually built into the comprehensive care. And as I said earlier, you can actually call them and get information on this as well, which is really helpful for us. In terms of decision making, I often refer patients to the CAN-HEAM position statement because they have a PDF on bone marrow transplantation. And I also direct them to the Sickle Cell Association of Alberta as well because they have resources as well. And so we'll sometimes talk through those resources and answer their questions. But generally speaking, that is something that is the focus of hematology.
Yeah, awesome. Thanks so much, Andrea. Great question. And Michael is just saying, thanks so much, Anila, for the talk. He has to sign off and zip to clinic, but we do have a couple more minutes if anyone has any further questions. But boy, I feel like we've covered quite a lot of ground. It's really interesting. Oh, here's Ashley. Okay, here we go. Her microphone doesn't appear to be working. She was wondering if you had suggestions for specific resources that nurses might be able to provide families or reference when providing education on guidelines for non-pharmacologic management in the community. Yeah, other things. Yeah.
Yeah, so that Healthcare Quality Ontario website that I talked to you about, they also have nurse-specific resources as well as non-pharmacotherapy resources. So that's something that I look at. That patient guide also includes that information, so that I linked in my presentation. So that would be one place. The Sickle Cell Association of Canada has resources that are really helpful. They have pamphlets, one pagers, apps. Another really great organization that was actually founded right here in Edmonton is called Not Just You, all one word. It's actually founded by an individual who has experienced sickle cell, and she has a ton of resources around what is sickle cell, how do you cope with it. There's also peer support groups. The peer support group is called Cells. So they have Cells Online, which is an online virtual group for adolescents and children with sickle cell, as well as Cells IRL, where they actually meet in person and have sharing circles and eat. They actually just had their Cells IRL for Black History Month last night, which is very cool. They also provide care packages to sickle cell warriors who are in ER, where they have like heating pads and snacks and water and all of these things. So she delivered 100,000 of them across the country. She put them
Oh,
in the
wow.
car and drove across the country and went to all the ERs. So Not Just You is a great resource if you have adolescents with sickle cell, adolescents to like university age, and they have great resources. And they also have a really active social media. So if you're dealing with adolescents, they tend to have their phones on them. So I would encourage your patients to follow them. They have a lot of events and a lot of really cool reels and information and a really awesome community. So those are some things that I think would be helpful for a nurse to provide. And then, of course, the different apps that I showed, like I Can Cope. Toronto Hospital for Sick Kids has great resources for kids who are a little bit younger. So there's a lot of different places you can go in order to get things connected for your patients.
Well, Eniola, you were saying you wanted to do the TikTok videos.
Yes, indeed. They can be effective.
Awesome. Oh my gosh, I can't believe 100,000 kids she dropped off. That's
Yeah.
incredible. That's like amazing. Oh wow. That just blows my mind. Okay, that's awesome, Ashley. Um, Adela, just last question for me. Like in terms of multi-morbidity and other things that people have or things people do. I mean, I'm imagining smoking would be particularly problematic. Um, are there other things that, other diseases and things that really need to be optimized in these youngsters? And
So as I mentioned in the monitoring, hypertension is a big one. So maintaining an individual having a normotensive blood pressure is really important, in particular when it comes to preventing cerebrovascular complications. Definitely no smoking and no vaping. So you definitely want to be early
right,
around. Please do not engage in smoking cannabis, tobacco, or vaping, particularly because acute chest crises are so big in terms of
right.
complication. And as we know, when you smoke, you impair your cilia, you increase your risk of having infections, your lungs are less healthy. So I really emphasize smoking cessation for people who do smoke or not actually starting smoking and people who don't yet. I think it's also really important to optimize other chronic disease. So in terms of maintaining a healthy cholesterol management, maintaining healthy sugars. As you know, having increased sugar in the blood also increases your hypercoagulability as well as your clotting. So it's really important for those things to be managed as well. So I really see that monitoring as a complement to the primary care monitoring we would do. But it's important to have those conversations around this is the guideline around how we have to look at sugars and blood pressure, and here's how it's actually modified because of this other thing you have over here. So it's a layered thing. It's complex in that way.
Wow. Yeah, amazing. Do we know, like we know with our little kitties with type 1 that diabetes that they often struggle with that whole transition periods in terms of self-management. Is it a similar kind of story with these kids as well? Is there pearls there on how to, I mean, I think all these resources you just said are amazing for them, but other strategies, is that
Yeah.
something you see too?
Definitely. So the adolescent to adult transition is a really fraught period for individuals with this condition, so much so that CanHEM actually has a guideline on how to manage the transition. Particularly going from pediatric hematology into adult hematology. As you
Mm.
can imagine, pediatric hematology is very comprehensive. There's a lot of resource around it. There's a lot of co-management. And then when individuals go from that to adult hematology, there can be a bit of a gap in services in
Mhm.
getting people moved on. And so it's very similar to what you experience in individuals with type 1 diabetes, where we have to be really
Mhm.
proactive. So I personally don't have any patients who are old enough for that transition yet, but it's already something that I'm thinking about and planning about. How am I going to make sure I have at least 6 months to a year of lead time in terms of getting them their next specialist
Yeah.
so that there isn't a gap in services? What services do they have that I can actually port to other things, right? What existing community supports can I help and leverage for this patient? So planning ahead is essential, particularly for individuals who are have more complex comorbidities, where they have had more complications or they have more frequent crises. It's really important to get ahead of the game, and that guideline is really helpful. So for anybody who's on the call who has a patient who is aging up, I really recommend reading the CanHEM adolescent transition guideline. It's really comprehensive and details everything that you would need to know.
Maybe we should put that in the pearls as a link.
Yeah,
Like
absolutely.
a
Yeah.
link in the pearls. Yeah, awesome. Well, gosh, I mean, thanks, Eniola. This is amazing. I know we're like 1 minute to clinic, but thank you so much. And I know you were up till all hours last night pulling all the final bits together. It was really great. I think everybody took a lot away from this and really appreciate you doing this.
Thank you so much.